Great. Awesome. Well, thank you all so much for joining us today for this important conversation. We're really thankful for our friends and colleagues from Virginia to come and talk to us about their Medicaid expansion implementation. I know that Medicaid expansion is on the front of mind for a lot of folks here in North Carolina, I think especially after yesterday's announcement that the September 1 deadline for passing a budget will not be met. And therefore, our October 1 initial rollout for Medicaid expansion is not going to be met either. So I know we are all waiting with bated breath for that to become a reality. I know that our team has been calling for the past hour into Senator Berger and Speaker Moore's offices to really encourage them to get this across the finish line, because 600,000 people in North Carolina are waiting for this. So we are eagerly awaiting, but the fight continues nevertheless. So we're really excited to have our folks from Virginia come and talk to us about how implementation went from them and some lessons learned. So for folks who do not know me, I'm Matt Martin. I serve as the Associate Director for the North Carolina AIDS Action Network, and really excited to have so many folks listening in today. And now I'm going to pass it over to my colleague, Lee Storo with Community Education Group.
Hey, everybody. Thanks again for joining us and being on this webinar on Tuesday afternoon. Community Education Group has been excited to collaborate and work with NC AIDS Action Network over the last couple of months to think about some strategic ways that we can help support and prepare for the rollout of Medicaid expansion in North Carolina. Community Education Group's a nonprofit focused on the syndemic of HIV, viral hepatitis, and substance use disorder, with a focus on rural America and the Appalachian region. We're headquartered in West Virginia, but certainly the work happening in North Carolina and Virginia is incredibly important and can have a ripple effect and lessons learned for the entire region. I do want to give a quick shout out, in addition to Matt and I, Sherry Giorgio with Gilead Sciences and Allison Rice, who is a longtime movement leader from North Carolina, retired from Duke Law, have been strategic partners as the four of us thought about what were some of the best ways to make sure the state of North Carolina was prepared for Medicaid expansion when it does happen. It is a hiccup this week that we're not going to be able to roll out October 1, but, I think all of us are pretty darn confident that it's inevitable at this point that we will finish the process of closing the Medicaid gap and expanding. It's just a question of when. So with that being said, we really felt like there were a lot of strategic reasons that having our partners and colleagues who followed this work, who did this work, both from a community level and an administrative level in the state of Virginia, had significant lessons learned for those of us doing work and supporting work in North Carolina. We have several speakers today who can help provide context, and without a doubt, I'm going to pass the baton off to our first one. I'm really excited that Kimberly Scott, who is the Ryan White HIV/AIDS Program Director at the Division of Disease Prevention at the Virginia Department of Health, is going to kick us off and present first. After that, we're going to pass things off to Kate McManus, who's going to provide a more community level researcher perspective on the rollout of Medicaid expansion in Virginia as well. We'll certainly have time for questions. I'd say if during the presentation, you have a burning question that you want to ask, feel free to drop it in the chat. But Matt and I will help sort of moderate that Q&A at the end of this conversation as well. So without a doubt, Kimberly Scott, I will pass the baton off to you.
Thank you, Lee. Good afternoon, everyone. It is a pleasure to actually be here today, because many people on the call may not know that I actually started out in Ryan White work in North Carolina. And that was when Part B was still called Title II money. And we were just developing consortia in the state. So it's a pleasure to be able to speak with you all today with my colleagues, and hopefully we can impart some information that'll be helpful to you during Medicaid expansion for North Carolina, which we're also really excited to see. I'm just going to give a high-level overview of some of the questions that you all sent in terms of things that the stakeholder community may be interested in hearing about. Then we'll turn it over to Kate, and then hopefully we'll have ample time for Q&A. For me to be able to start this discussion, as I always do, I have to give a big shout out to the Louisiana State ADAP, who assisted Virginia when our Medicaid expansion came into place. They had gone through Medicaid expansion. Our programs are very similar. And so they helped us develop our transition plan, allowed us to use various communications that they had already developed. Luckily, our Virginia Medicaid colleagues also paired with their colleagues in Louisiana to learn and apply best practices, many of which included lots of focus on communication, weekly statewide calls and town halls by the Medicaid director for people to learn about the process and ask questions as it unfolded. So just to give you a broad overview of some of the responses based on the questions, one of them was, what did the Virginia Rhine-White program do to transition ADAPs to Medicaid? And how did we approach the timing of transitioning to recipients, to ADAP recipients? Virginia started almost a year prior to expansion implementation. We knew the targeted date, which was January 1, 2019. And so we started trying to figure out what would we need to do to engage everyone and to ensure people were ready. So what did we need to do for clients? What did we need to do for providers? What did we need to do for our own staff? So there were a lot of presentations to our Rhine-White providers a year prior to implementation, and to also in the surrounding jurisdictions that have clients who live and work in Virginia, but may live in Virginia and receive services, but may work in some of those neighboring jurisdictions like DC and Maryland. Some of those communications, every communication included action steps at the time, and we updated those presentations. So we require our providers to meet quarterly here in Virginia for the Rhine-White program. So while we meet quarterly to do updates on the program, there's also quarterly meetings for our ADAP stakeholders. There are quarterly meetings for our quality management advisory committee. We have a very robust consumer advisory committee called the Virginia Consumer Advisory Committee, or VACAC. I will try to minimize acronyms during this discussion, but we all know what happens when we start talking in this field. I might even make up a few before the end of the day. So we had action steps in there, and they always focused on client and provider action steps and tune-ups. For clients, we were always focused on client eligibility. What were going to be the eligibility criteria for Medicaid expansion? What types of services would be provided, because people wanted assurances about the service provision and could they keep their same providers. For the providers, we focused on assuring that they checked which plans were they accepted from the Medicaid MCOs, and that they focused on their credentialing and contracting statuses with the MCOs well before expansion was going to start, because come January 1, if they didn't have their credentialing in place, then they were going to be concerned about not being able to be reimbursed. We also encourage people to check our websites, because that's where we were going to post information. I'll talk about that a little bit more, and start looking for information and not waiting for it to be pushed out. And also to agree to provide peer technical assistance, because the more some agencies learned and what they did working with their clients and that worked and what didn't work, they'd be able to provide that peer TA. The provider and the presentations also focused on the overarching goals of Medicaid expansion. And I would say this is one of the really important lessons, because it is not simply checking a box that your eligible clients would then receive services. In Virginia, Medicaid expansion was going to provide services for an additional 400,000 people, just about of Virginians. But for us, based on our programmatic data, because we started looking as soon as we heard program Medicaid expansion, and as soon as we learned from Louisiana how they planned for waves of enrollment, and I'll talk about that in a minute, we found that approximately 4,000 of our ADAP clients were Medicaid eligible based on our programmatic data. That was about 60% of our clients. So in focusing on the overarching goals of Medicaid expansion, things like wellness and prevention, expanded chronic case and disease management, providing comprehensive care, decreasing the use of the ED, and addressing social determinants of health. Those were things we could go back to after enrollment kind of leveled out for our programs to really focus on how to make our systems more robust, learn what Medicaid was doing, and to partner with them on some of these different initiatives. So it's not just about checking a box to make sure that your clients are eligible and enrolled for services. And as an FYI, our Virginia Ryan White Part B team is meeting with the North Carolina Part B team for technical assistance and really drilling down on logistics. So we're not going to focus on a lot of that here. We also did online surveys for Ryan White Cross Part providers in Virginia. We have A, B, C, and D to identify which plans they accepted and to determine the clinical adequacy of our own provider network. So there were lots of different pieces to look at: system strengthening, clinical adequacy, how many clients are going to be eligible, where were the clients in the state, because we found that the majority of the clients were in one health region in the state, which then helped us be able to develop health equity initiatives later without the focus of Medicaid enrollment. You all asked about some of the most impactful ways to communicate with clients who were newly eligible for Medicaid. So from the ADAP program specifically, our communication focused on outreach, enrollment, and after enrollment. And they were further divided by those who were already insured and those who were not insured. And we defined who would be potentially eligible based on Virginia Medicaid's income eligibility criteria in these letters. So pre-expansion, everybody got a letter. And we know that letters aren't the best way to communicate with people, but it was a way for us to start and said, Medicaid expansion is coming. We just want you to know about it. We're going to be communicating with you again. We then sent out a tailored communication for clients who were uninsured, which would be our direct ADAP clients. And then for our insured clients who we learned from our programmatic data at least, may be Medicaid eligible. Those were clients who we insured under the ACA, Medicare Part D, and those who had employer-based insurance. For people who were in direct ADAP, we sent out medication bag inserts from wherever they picked up their medications, and that content was rolling content. Some of it was informational, some of it is, we need you to start checking your mail. Then it was, we need you to open your mail. We need you to talk with your case managers about whether you're eligible for Medicaid. We're going to have our insurance benefits manager contact you because we believe you're Medicaid eligible. So the content of those inserts would change, as would our letter campaign. At the time, we had limited use of social media. We now have better access to social media to be able to communicate with clients, but we did use our typical social media accounts here at VDH and also ran ads on Facebook. We posted information to our programmatic websites. We sent out information from Virginia Medicaid and reminded clients to open their mail. We used our listservs to be able to do that. I would stop here and say that Virginia Medicaid did a lovely job of communicating with clients. They did focus groups. They really focused on their messaging. Their content was real plain language, very clear. They did a lovely job color coding communications to go out to Medicaid clients and beneficiaries who had current Medicaid eligibility. And so you got some instructions if you got a yellow envelope or a pink envelope or a green envelope. They auto-enrolled many eligible beneficiaries for the first year. They hired a third-party vendor to manage their call center and maintain their website, and they were able to do enrollments over the phone. That was a critical infrastructure investment that Medicaid made that ensured that these 400,000 people, who would include our 4,000 clients, would be able to enroll quickly. We have a co-branded website with our insurance benefits manager, and we drive clients and providers to that site. It was linked to the Virginia Medicaid site. It had a little calculator and a test for people to answer 5 simple questions to see if they were Medicaid eligible. If they were, our insurance benefits manager could assist them in enrolling in Medicaid. We asked for reminders during case management appointments. Our insurance benefits manager did do direct outreach to clients and said, hi, how are you? This is Benalytics. I'm calling on behalf of Virginia ADAP. Our information says that you are eligible for Medicaid. We'd like to talk with you about that and like to help you enroll. Do you have time now? If they didn't have time, they could set up an appointment for the benefits manager if they didn't hang up on them. So, that's good. We're going to be talking about that in the pain points. Any meeting where we had consumer membership, there were updates, and we also engaged our VACAC to do educational messaging either through their regional meetings, any trainings that they were doing for consumers to talk about what steps were coming. And part of what we wanted to do was to talk about everyone to do health literacy, to talk about the importance of insurance coverage for best health outcomes and health management, period, regardless of whether you got it through Medicaid, but that to give assurances that that same quality of care could be provided through Medicaid coverage. Many of the providers we hoped would be in network, and that the transition would be as seamless as possible. We also had VDH staff who work on our hotline that's to get information about STIs and resources. We actually had them in their downtime call clients to verify their Medicaid enrollment, ask about their medication access through their pharmaceutical benefit, and encourage them to reach out to Ryan White providers for services they needed that were not covered by Medicaid. And often that was a pain point for patients of learning what's Medicaid covered service, what's a Ryan White cover service, and then what were wraparound services. And we did this especially for older adults. I would say what worked and didn't work. What were the pain points for clients making transitions? And I'm going to wrap this up very quickly. Clients wanting to stay either on direct ADAP or in insurance provided by the Ryan White program. The familiarity and safety of the Ryan White program became the challenge for transition for many clients. And assurances that their providers would remain the same, understand how their medication access would change. Structurally, the services are the same. You pick it up from a medication site, you get it from a retail pharmacy, you get it from mail order, but just going through the process through Medicaid. And I would say, what lessons did we learn that might be helpful for you? Relationships at every level between your Ryan White program and your Medicaid program, from your pharmacy, who did a crosswalk of the Medicaid MCO formularies to our ADAP formulary, down to your policy people and your programmatic people and your folks who do eligibility, and do this bi-directional education about processes for providers to not only enroll with all the MCOs and send that information, but to share with your Medicaid counterparts what services you provide, what are your eligibility processes, and being able to share information. We did a crosswalk of Ryan White services to Medicaid services to help our providers understand what did Medicaid provide, what did Ryan White provide, and what fell in the gray area that we made wraparound services. And I would say using data agreements and exchange between your programs and Medicaid is critical. If you don't have a data sharing agreement, you have to get one in place, and it will help you not only be able to perhaps do batch matching to understand and verify clients are enrolled in Medicaid and using their pharmaceutical benefit before you disenroll clients from ADAP, if that's what you choose to do. It also helped us do reconciliation of our estimates of clients to actual enrolled, but it also helped us with future data requests and initiatives with Medicaid, where we were working with them, and to think about how you can leverage the overarching goals of North Carolina Medicaid expansion to improve your services, not just what they'll provide. For Virginia, that became integration of trauma-informed services and health and healing-centered approaches into our HIV service delivery, engaging people with lived experience. Our VACAC was invaluable, and where they also overlapped with CABS and QMAX and CPG and everything else. So have regular meetings with your colleagues, learn the steps in the progress for expansion, instruct clients and providers, share what you're doing to prepare your client population. Share your successes and challenges. One of the things that we learned, having the programmatic relationship for people who dealt with client eligibility for Medicaid often helped us resolve enrollment issues without formal appeals. So those relationships will serve you well throughout your entire programmatic process. Every single convening that you have, talk about Medicaid expansion, progressive steps, action steps, what's working for you, what are the challenges that you see still ahead of you, and how can people help you? And I would say adopt and tailor some of these action steps to your needs. That's the very high level overview of sort of what we did to prepare for the the waves of enrollment, and the fact that Medicaid enrollment, also remind people, Medicaid enrollment in Virginia is continual. So there's not a there's not a dedicated enrollment period. That also helped us be able to plan our waves of disenrollment from ADAP after they were enrolled in Medicaid, and to make sure, and we always wanted to make sure that no one fell between the cracks. So if there's any question, then we provided medication access through direct ADAP while we're trying to sort out the person's medical coverage home, while also adhering to the Ryan-White requirement for payer of last resort.
Awesome. Kimberly, I know, I think we all know in North Carolina that this is substantial work and hard work and long work. And I think, thinking through all the pieces of what y'all did from an administrative angle in Virginia certainly reinforce that, and reinforce, I think, the work that the community from a public education perspective and building all of this together need to be thinking about doing over the weeks, months, and years ahead. So next, I'm going to pass the baton to Kathleen McManus. Dr. McManus is a professor at the University of Virginia in their School of Medicine with a focus on infectious diseases and international health. She's been a longtime advocate for access to healthcare, particularly with an eye toward folks living with HIV, and excited to hear some of the work that she helped do to think about transitioning patients within her clinic and within the state of Virginia, and how that can apply to our work in North Carolina. Dr. McManus, passing it off to you.
Great, thank you. So glad to be here with all of you, and always great to present with my colleague Kimberly Scott, because we do get to do a lot of work together. So it's nice to get to present together as well, and you can see things from different levels and different angles. So I'm gonna share some slides. Let's see. I think hopefully they're visible now. Yes. Okay. Great. Since I am going to be presenting some research, first I just need to give my disclosures about the work that I'm going to show. And I also want to acknowledge the village that it takes to do this sort of research, to be thinking about how do we make sure that the community has access to the care that they need so that people with HIV can live healthy lives. So back in 2014, we'll just go back to that time period, we knew that we were not going to get Medicaid expansion. And so actually the AIDS drug assistance program clients, none would be moving to Medicaid due to Medicaid expansion. And Virginia Department of Health and the AIDS drug assistance program in Virginia were incredibly innovative. And while a lot of groups were purchasing these Affordable Care Act qualified health plans, Virginia did it to a degree that they were really a leader in this. So the first year, actually 50% of ADAP clients shifted to these ACA qualified health plans. And we were lucky enough to do a UVA VDH partnership to study the impact. So with QHPs, we actually found that ADAP clients had higher rates of viral suppression, and it was statistically significant, and actually cost VDH less money. So we went through kind of a big transition from 2013 to 2014, trying to transition a lot of ADAP clients onto these ACA qualified health plans. So we knew a lot about kind of care transitions, coverage transitions. So fast forward to 2018, when we hear that we are going to get Medicaid expansion. So it's exciting that our patients would have access to Medicaid coverage, knowing that they would have then insurance. People who are uninsured would have insurance and be able to get access not only to great HIV care through Ryan-White, but be able to get that colonoscopy, be able to see a cardiologist, really important things. I think one of the things that made Virginia unique was that many ADAP clients were not going to be going from uninsured to Medicaid. They were going to be going from ADAP subsidized qualified health plans to Medicaid. So that is a little bit of a difference when you're thinking about people's access, and it's not a transition from no coverage, it's a transition between two different types of coverage. This is pertinent to North Carolina. Of the, from 2021, the data showed that there were just over 10,000 ADAP clients, and about 15% of those had ADAP subsidized qualified health plans. So presumably a large percentage of those patients will be eligible for Medicaid. And so you'll need to be thinking about those people, not going from uninsured to insured, but from one type of coverage to another. So I'd say that's an important caveat to think about. Just to pause and give you kind of, I think I look at this from a few different angles. So first, I'm a Ryan White clinician. So I'm in the clinic, I'm seeing patients. When this came out in 2018, I was very excited for my patients, but it was also very daunting because we had done that transition from 2013 to 2014 and getting people enrolled in qualified health plans, and the huge lift that it took from our case management team, our social workers, knowing that people would come to clinic with questions, and if they saw a medical provider who didn't know as much about this, maybe those things weren't addressed appropriately. So trying to think about how do we prepare our clinic, our clinicians, everybody in the clinic to be ready to help with this transition. It was a little bit daunting, and I would say we had some talks through the clinic, like how are we going to do this and get everyone on board. So we definitely tried to do some education to everybody in the clinic about, hey, this is, okay, remember that 2013, 2014 transition. We're going to be having a similar very large transition where people are going to be going from uninsured to Medicaid, or from ACA qualified health plans to Medicaid, and trying to get everybody on board with this is something that really everyone needs to be aware of and needs to be thinking about. It also was daunting because a lot of times we only see people twice a year. So trying to make sure that we were going to be able to see people and tell them and warn them about this potential change, in the last 6 months of the year before it would happen in January, we knew that we weren't going to see everybody. So it was really important that we knew that there was going to be ADAP communication through letters, as well as communication from Medicaid, as well as the information in the medication bags when people picked up medication from direct ADAP. So that was really important. But we also sent out some messages through our clinic, actually has a mobile health app. So we were able to push out messaging through the mobile health app to try to get people ready. And like Kimberly mentioned, we were mentioning things like, please open your mail because, and please update your addresses. Sometimes people might move quite often, and so they might not always keep all their addresses updated. So we were trying to stress the importance of keep your addresses updated. And we know it's antiquated, but a lot of this is going to be like paper mail, and you need to be opening the mail. And we told people, if you get mail and you don't understand it, please bring it to the clinic and we'll help go through it and help you decipher what it might mean. So that was really big. And then we also, I think one of the big things also that we find is that these issues don't always come up in the clinic in January, because often someone might fill their meds like late in December, or maybe the insurance company might give them a fill in January thinking a premium payment is coming. And then really these issues might happen in February. So that was something that we talked about in terms of the timing. Like, just because you were able to get your medications in January does not mean you're out of the woods. You need to, be making sure that you can still get them in February. And I did see a few patients in May and June who said, yeah, I couldn't get my medicine and it was too much of a hassle. And so I haven't had meds since December. So we did see that in the clinic. And these were people who were engaged in care. They showed up for their every 6-month appointments, but the hassle of figuring out this transition was too much. They didn't call us. And so we didn't know to help with it. So I would say the more proactive clinics and organizations can be, and the more that we can prepare people and let them know, hey, we're here to help, call us, will be a low barrier entry point to figure this out, I think is really, really important. So that's kind of the Ryan White clinician angle. As a physician scientist, I've studied, how do our patients get access to care, and what does this mean for people? Kind of in this implementation science dissemination area of research, really what I think the research that matters the most, because you can develop the most amazing antiretroviral therapy, But if we can't actually get it into people's hands, then what does it mean? So we looked in our clinic to try to understand what did Medicaid expansion mean for our patient population. So I'm going to share some of this data with you here. So in our clinic, looking at the data from 2018 to 2019, there were 151 people who we could tell were eligible for Medicaid. When we looked at the 1 year mark, about half of them had shifted over to Medicaid overall. And then when we looked at people who had individual private insurance, so probably most of these people had ADAP qualified health plans, 60% had transitioned fully to Medicaid. When we looked at people who had employment-based private insurance in 2018, there were 14 people who were eligible and 20% of them had shifted over fully to Medicaid. And when we looked at our uninsured client population, there were 34 who were eligible for Medicaid from what we could tell, and 35% had shifted over. So just something to show that, even when there was like so much work at the state level, so much work at our clinic level, it was on everyone's radars, we still didn't get everybody shifted over to Medicaid. So I think that's really important. And, this was obviously a snapshot in 2019 and the work has continued. So I think we probably have been more successful in getting more people over and getting them coverage. We looked at viral suppression. So this is for 2019, viral suppression in our clinic based on people's insurance. And so 90% would be our goal, or what we like to see at least. I think it's important to note that historically for Medicaid, 65 to 68% has been the viral suppression rate that's been published. So our patients who are on Medicaid did have higher rates of viral suppression than that. We had people who were previously on Medicaid and continued on Medicaid were at 87% viral suppression, and people who newly got Medicaid expansion were at 85%. So above the historical Medicaid viral suppression rates, but lower than kind of the other patient populations in our clinic. So not what we hoped to see. We did look at this with an adjusted model to try to understand. We were able to control for age and baseline viral suppression. The numbers were so small that we actually couldn't include income in the model. But we did see that when we adjusted for age and baseline viral suppression, being on Medicaid or having Medicaid through Medicaid expansion was associated with lower rates of viral suppression. It was significant. We thought, well, maybe was this something to do with a change in engagement in care? And so we looked at people's engagement in care, but there was no difference in the engagement of care of these Medicaid and Medicaid expansion populations. So I think the next important step was, can we understand why? This wasn't the outcome that we hoped to find. We hoped to find at least equivalence. But I think we know that sometimes when we make transitions in the healthcare system, there can be challenges and unintended consequences, and there can be kind of blips before we have improvements. So we decided to talk to people about their experiences. So this was in our clinic, and we talked to more than a third of people who transitioned to Medicaid due to Medicaid expansion. It was 28 people. And people had really positive things to say overall. So mostly positive perceptions of Medicaid, both before and after enrollment, which was great, because we had heard some whisperings that maybe people didn't want Medicaid or didn't think Medicaid was going to provide as good care. Most people felt that their own health improved after Medicaid enrollment, and that Medicaid did allow people with HIV to have good care. And specific positive things that people talked about: the affordability of the care, access to HIV care and other medical and dental care, access to HIV and non-HIV medications, and transportation assistance. Some of the negative things that people shared with us, they said that there was a lot of difficulty understanding insurance-related information, challenges with the enrollment and re-enrollment process, interruptions in access to care and medications due to re-enrollment problems or changes in insurance providers, unexpected increase in costs for medications or services not sufficiently covered. So there were co-pays when people first shifted over to Medicaid in Virginia. And then there were some missed appointments due to cost concerns and unreliable transportation. So while transportation was a benefit, some areas of the state, people had difficulty actually finding people who would provide the Medicaid covered transportation. So I think one of the big things that I want to stress, and that probably all of us know, but I just want to pause to say it, is that insurance coverage transitions are hard. Even with a lot of support from the clinic, this transition was really hard. And the logistics in coverage and access and transitions in coverage and access are hard, and they take a toll on the patients and on clinic program and staff. So I think as you work through this, having a lot of grace, for lack of a better word, for everybody dealing with these challenges, it can be really hard. And then, why did we see that dip in viral suppression? So one of the biggest things that we think could have contributed to this was that we heard that people had trouble getting their medications due to gaps, which we might expect. So there might have been a gap between previous coverage and Medicaid, but the thing that we didn't really anticipate that was a problem was this overlap. So people said they would go to try to get their medicine, and Medicaid would say, no, you have this other coverage, and the other coverage would say, no, you have Medicaid. And so I think preparing people for the fact that, okay, gaps or overlaps both can be problematic, and both of those should trigger a call to a clinic or an organization or someone who can help you get past this and figure out who is the coverage that should be covering this. And this is pertinent to North Carolina. Of the just over 10,000 ADAP clients in 2021, 70% would be estimated to be newly eligible for Medicaid due to for Medicaid expansion, and that's due to data from the NASDAQ ADAP monitoring report. And then about 15% could be transitioning from qualified health plans. So those would be two things to look out for as people are transitioning between programs. I think the other thing that we know is that people's incomes are not static. And so as people's incomes fluctuate, people will be, they will become eligible or ineligible for different programs. And so that's something that we need to be looking out for and explaining to people and helping them to realize. So one year you might be on Medicaid, and then maybe you make too much money and you need to shift to AIDS drug assistance program. And so those sorts of churns and transitions are also things to prepare people for. So it's not like, okay, I go on to Medicaid and then I stay on Medicaid. So that's a big thing. So also we asked people kind of what should we do in the future, or what would you like to see? What would have helped? So people said more access or easier access to information about Medicaid, and more explanation of Medicaid benefits. So we know there was a lot of great communication, but I think thinking about how do you reach people through mail, through social media, like Kimberly said, how do we get the message out through like every different pathway and make sure it's really accessible? Other suggestions were more assistance with enrollment, improvements in the enrollment and re-enrollment process, better coverage, lower cost to patients, improvements in the transportation assistance, which actually, if we can't find coverage if someone has Medicaid but can't get transportation through Medicaid, we are able to use our Ryan White Part B funds, and that's been a communication between our clinic and the state. So those sorts of things have been really helpful once we heard it from patients and clients. And then ensuring uninterrupted, timely access to medication, which is really just so crucial. I think the next thing I want to stress is the importance of partnerships, so sharing stories and data. So we had the opportunity to share our studies about Medicaid expansion with Virginia Medicaid leadership. And this was mostly because they saw some press about the articles, and one of our co-authors had a personal relationship with Virginia Medicaid working on hepatitis C work. And so they saw this HIV work and reached out to say they want to hear about it. And we were also able to share some of the details about how many of the people with HIV who were newly on Medicaid had transitioned from AIDS drug assistance programs. And so that was something that was really helpful for Medicaid, Virginia Medicaid leadership to hear about, and actually kind of triggered them to do the comparison between like, okay, well, what does Medicaid cover and what does ADAP cover, and how can we align those two things, since people are going to be kind of churning in and out of these two programs. And so Medicaid leadership actually analyzed the formularies of there are 7 different Medicaid programs. They have a fee for service and then 6 managed care organization Medicaid plans. And when they looked at this, they found that actually 22% of ART medications were preferred by all plans, but of the top 10 ART medications, really only raltegravir and dolutegravir were preferred by all plans. So the 22% of ART medications maybe weren't the most used ones, so that's not as helpful. Across the plans, they found that between a third and almost 60% of single tablet regimens were restricted. And so then even if those were preferred, many times people had to use specialty pharmacy, which was a barrier. So Actually, this led to some really positive change in Virginia in January 1st, 2022. Across fee-for-service Medicaid and 6 managed care organization Medicaid plans, they aligned their formularies. So there's 7 identical formularies and 1 set of rules. So this makes things a lot easier for clinics, organizations, patients. People transition onto the fee-for-service and then go to a managed care plan. And so when they make that transition, it's more seamless because they know that they'll still have access to the same medications. All ART medications are now preferred with one exception. Clinicians can prove the appropriate ART without prior authorization, standard criteria across plans. All first-line ART and Rapid Start ART are available at retail pharmacies, and all the medications are eligible for 90-day supplies. So this was a huge thing that Virginia Medicaid did to really improve access for our patient population. They also have done some other really wonderful things. They align the drug formulators between ADAP and Medicaid. They remove prior authorizations on medications for HIV and co-occurring conditions. Remove the co-pays on medications reimbursed for televisits, and right now they're working to leverage the pharmacy data to identify interruptions in care and activate outreach. So a lot of really proactive, positive things. And that clearly came out of a partnership between our research team, VDH, and the Virginia Medicaid leadership. That was a really big win for all of us. And really for the community, which is what matters. So I think the 3 things that I want to leave you with, again, the changes in care access and coverage are hard for people, and Ryan White HIV/AIDS program funded clinics and programs need to do whatever they can to make this easier for patients and for staff. And we need to have grace with each other as you manage these transitions. Everyone doesn't need to know all the ins and outs about Medicaid expansion, but everyone needs to know what to listen for and where to refer or whom to refer people for assistance. I think that's really crucial. As a clinician, I know that this is not something that every clinician is interested in, but I think we should be. And so I think equipping everyone on the team to know, what are the problem things to listen for and who should I send them to? And then forming partnerships and setting up times to proactively talk about what everyone's seeing. You really need frontline stories and data to inspire and support change. So it was the data that we were able to show Medicaid as well as patient stories that we were able to email them about that led to those really dramatic changes that we were able to see. And with that, I'll stop sharing and I think we'll open it up for questions or discussion.
Yes, let me add the folks the spotlight. That way y'all are easy to find and see. All right, I know that we do have one question in the chat, and I'll ask for other folks if you want to drop in the chat, that's fine, raise your hand, whatever is easiest for you. But the question in the chat is the copay elimination that was mentioned, was that just for HIV drugs, or was it just for people living with HIV or across the board for Medicaid patients?
Really, do you know for sure?
I believe that it was just for patients with HIV, but that is something that we can check and get back to you. And our program also was prepared, especially our ADAP program, to pick up any cost shares if there were any for clients in terms of Medicaid expansion. And there were no cost shares for clients during Medicaid expansion, but we still had this larger population of people who had Medicaid eligibility based on other circumstances and criteria, as well as our dual eligible clients.
Yeah, I would say I can't remember what our Medicaid colleagues shared with us, and so we can go back to them and ask. And I would say I think while there was going to be no cost share, I think people really worried about, hey, I'm switching to Medicaid, and I know my friend down the street who has Medicaid has to pay a copay, and so I think people were worried about the copay. So it's not always what people experience, but it's a perception of what might happen. So I think the more education around those sorts of issues at all levels would be really important, and we probably still need to continue to work on that.
Right. What other questions do folks have?
I see Kimberly Scott's message that case managers are really important. They were like so essential. I often say that when people come to clinic, I am the least important person they see, and that like pulling in our community health workers, our case managers, social work, all the team members who can help make sure that these medications get to people, that people are getting the services and the care that they need.
I'd be intrigued to know, you know, a lot. I know this conversation largely focused on folks living with HIV. I know for those of us doing advocacy work around Medicaid expansion, there's been a lot of interest in it being a pathway to PrEP and to other prevention tools, to regular STI testing for folks who are HIV negative. Do y'all have any thoughts? And that could probably be its own whole conversation, but just about how Medicaid expansion impacted prevention efforts and broader sexual health efforts in Virginia?
So I'll respond to some of that. I think that we are seeing improvements, but I don't think that there's parity yet. For example, long-acting antiretrovirals, either for people with HIV or for prevention, aren't on our formularies. And I think in terms of really focusing around testing and routine testing, and especially testing in all EDs and in other places where people are seeking care, I think that we're hoping to still see a lot of progress in that area. But the fact that one of the overarching goals of Medicaid for Medicaid expansion was to focus on wellness and prevention, I think there is a foundation for us to keep working on seeing, as Kate was saying, equivalency, even if it's not in terms of cost of services, and it may not be provision of all medications, but trying to get to some parity and really focusing on what would be available for biomedical interventions for prevention. And at the same time, not just for HIV prevention, but also pulling along hepatitis C as well, in that suite of services and policies.
All right, looks like we've got a couple more questions in the chat. So Linda Connor asks, do patients have a choice of which plan they are enrolled in, or do they have a choice?
And Kimberly E., you can also help respond to these questions. As I said, she's our ADAP coordinator. But patients were enrolled in a plan, and then they had an opportunity to change their plan within a specific time period. Am I remembering correctly? Because I'm aging by the day, Kimberly E.
Me too. But now initially with the expansion happened, they were placed into general fee-for-service Medicaid, and they were given a certain amount of days to actually choose a managed care plan. If they did not choose a plan, then Medicaid would place them in one automatically. And I believe that time frame, I think it was 90 days. We can verify, but I think it was around the 90-day time frame. But they had to move into an MCO. That was just the cost-saving method for the Medicaid program in Virginia.
I think figuring out what that's going to look like in North Carolina and doing education around that is huge, because I think that caused a lot of issues where someone was in fee for service. And so we'd prescribe ART, and at that time we were still prescribing 30-day supplies. And so they can pick up for 3 times or 2 times, and then they're in an MCO and the rules were completely different. So I think that then, you know, the client didn't know, you know, if they didn't pick their MCO, they didn't know that they were getting switched into one. The provider didn't know. So there was a lot of like, well, what's the problem? You were in Medicaid, you're still in Medicaid. Like there was a lot of confusion around that. So I think the more you can understand about that process, what it's going to look like in North Carolina, the better.
Next question that we have is from Haley Cunningham. How did you handle the overlap periods or gaps in coverage?
So for the overlap periods where we found that individuals, to Dr. McManus's point, where they were enrolled in ACA plans previously and were switching to Medicaid, It wasn't as seamless as we thought it would be. One of the primary things that I remember occurring was there was not that automatic disenrollment that we were kind of told would happen. So if our patients didn't actually disenroll from those ACA plans and they were enrolled in Medicaid, it looked like they had dual coverage, and they really didn't, because we were no longer paying those ACA premiums. So it took us a bit of work just to get clients back to our insurance benefit manager. That was the way we chose to handle it, to get them there to them so they can help them make the phone calls to address what were the actual coverage end dates, so that we could direct the client to where they should be in order to get their medications. Now, if there ended up being any other sort of conflict or non-resolution, we service them through direct map just to make sure we could keep them in medication access. Same thing when there was gaps in coverages. Let's say their coverage ended in ACA, at the end of December, but they didn't enroll into their Medicaid until March 1st. Those 2 months in January and February, we covered them in our direct map program, so that they could still maintain their medication access.
All right, Charla asked, when you created your work groups or committees to prepare for the expansion a year prior, did you include specific people, or did it mostly consist of your Ryan White specialists, case managers, social workers, etc.?
For the Virginia Department of Health, it concentrically involved invitations for people, depending on what we discovered, where we were in terms of our specific transitional plan. So in the beginning, it was very small. It was our VDH staff, Ryan White staff, and our colleagues at Medicaid. And we didn't have all of those specific relationships. We just said, wouldn't it be great if we could get together and be able to talk and find out what's going on? And we would always schlep up to the Medicaid building from VDH. And it allowed us to be able to do a lot of information sharing and education in the beginning. And then the problem solving grew from that. So we had to meet policy analysts, and we were like, okay, here are the people we want to bring from VDH. And they said, here are the people we want to bring from Medicaid. And then from there, there were concentric rings of invitations for people as we needed additional input.
Right, and then Allison asked, when you referred to auto enrollment, was that into Medicaid Direct or into an MCO plan after they had enrolled in Medicaid?
Kimberly, I want to say that those auto enrollments were into MCO plans because it was from people with existing Medicaid coverage that either for services that were going to be discontinued or coverage that would be discontinued, or where they recognized that people had limited services in Medicaid. So those services for reproductive health programs, they auto enrolled those individuals into an MCO plan, and then they still had the opportunity to make a change within the 60 to 90-day period if they wanted to change MCOs.
Correct. That is correct.
Awesome. And then someone else asked, didn't the MCOs vary by geographic region?
I had a nifty map here. The regions actually, they did vary by region, and although there was statewide coverage, some of the MCOs did have limited or limited geographic catchment area for services. So they all provide, there was statewide coverage, but every MCO did not provide services for the entire state. It's kind of like how our because the MCOs were the same carriers who were in our marketplace and offering our marketplace plans. And so in some times it sort of mirrored that. And I don't remember that there was ever a place that did not have any coverage within the state.
No, there wasn't.
I think that's an important thing in a state like Virginia, where we have people where they might live in one city, work in another city, and then get care in a third city, due to some of the issues around stigma still. So I think that's another thing you might want to think about in North Carolina, is just making sure that, like, when people do pick these plans, that, okay, it's not based on where they live, but where they want to seek care. Just because I know that people can travel long distances, basically if they're in a rural area, or because they don't want to seek care in their small town.
Yeah, that's very important to note. So we're about 2 minutes out. I will give folks another second to drop any questions. I know a question that I had, not specific to like how y'all implemented stuff, but just kind of like a potential feedback or suggestions for North Carolina, particularly right now as we go through the unwinding period, and people who would be eligible for expansion who are going to be denied until expansion becomes a reality, and then like communicating that they are now eligible again, particularly around that trust that I feel like could be lost between like losing coverage, not wanting to re-enroll in coverage. Any words of wisdom or thoughts of how we can communicate with our folks to make sure that there's as little drop off as possible?
That is a really unique circumstance you have, and thank goodness our expansion happened before unwinding. Um, I think going back to what Kate said of really making sure that people know the pieces they need to know, and really drilling down to help people understand what unwinding means and why it affects them in one way, and what expansion means and why and how it can undo that, that. And it's not even a perceived negative effect. It is. If you get disenrolled, you're beginning to worry about your coverage, you're beginning to worry about your access to care and medications for yourself, potentially for your family. So I think you all have the unenviable task of really explaining lots of plain language and making sure you all are giving the same message. If you take every opportunity for all the stakeholders to convey the message, make sure you've got your consistent messages, develop your messaging map, and then decide who are going to be your experts to be able to answer additional questions, because everybody doesn't know that. If you're not doing this day in and day out, you're not going to know that. So I think if you can structure your communication plan in that way, then I think you would have more success than not. And if you've got social media, any way that you can convey that information, and using public service announcements. That's the other thing, is don't forget, you can ask your Medicaid or your Department of Health to ask to use some of those public service announcement slots that are required to be provided on a monthly basis to help you communicate what's happening with Medicaid, the unwinding piece and the expansion piece, because it would be really easy, I think, for people to get lost. And and where you all have to think about the greatest impact is that going to end up being a huge additional cost to your direct ADAP program?
I think I would add that, like, on an individual level in clinic, I often will acknowledge, like, this system is broken. Yes, this system is broken. You are unenrolled because of this stupid whatever unwinding, but you are going to be eligible again, or we need to reassess your eligibility, like, once it expands. And I think sometimes just like acknowledging with the person, like, how messed up our system is goes a long way, because sometimes we're viewed as part of the system, but we obviously are in the system, but we're trying to change it and fix it and make it better. And so I think that when we can make that clear to the people who are frustrated with their coverage or getting unenrolled or disenrolled and shifted all around, like, it aligns us and makes us on the same team. So like I try that, I use that often, and that's the truth. So I think that goes a long way. And I think, like, that's one thing. I think if someone could come up with some kind of catchy way, like, okay, there was an unwinding, but there's going to be a I don't know, like some kind of catchy thing that you could all be saying. Like there's an unwinding, but there needs to be, I can't think of anything on the fly, but
Unwind, but rewind.
yeah, that's
Or
what kept
that-
going in my head. But I'm like, I don't know if that makes sense, but some
Yeah.
kind of phrase like that, like, okay, there's an unwind, but yeah, let's rewind and check your eligibility or something. I don't know. But I think if you could get everyone having a consistent message, like Kimberly said, from the top to the bottom, like everyone on the front line saying it coming from the state, I think that would help a lot. And acknowledging the system is broken. We're going to try to fix it as best we can, but within the system, you're going to get disenrolled and then we'll reassess and hopefully you can get re-enrolled.
And maybe part of your key message is around keep your coverage, because that's a key message from Medicaid right now and from all of us adopting the message. So in that, you don't have to go into the details of this is why you're going to lose it, but this is how you're going to keep it. But if your campaign is around keep your coverage, then you're going to help everybody understand what they need to do to keep their coverage. But it may be different steps and at different times, and they may need help from different stakeholders.
Awesome. Well, we are at the 3:03 mark. We're a couple minutes over, but we cannot thank y'all enough for your wealth of information. I think this was extremely helpful as we think through kind of next steps here in North Carolina. So with that, I will give everybody back their Tuesday. Y'all have a great rest of your day and a great week and heading into a long weekend. And thank you again to our friends of Virginia. Y'all have a great
Thank you, and be aware of Idalia. We always reach out to our North Carolina colleagues anytime there are storms and things like that, in case you all need any assistance. So be safe down there.
Awesome.
Thank you.
Bye bye. Thank you very
Bye.
much.